This patient whom we are going to do an ERCP today is a young female patient who came with recurrent attacks of cholangitis. Her liver function tests were abnormal and an ultrasound scan showed that she had a dilated CBD with small filling defects. The gallbladder was distended with stones in the gallbladder. So, essentially we have a patient here with common bile duct stones with recurrent cholangitis in whom we are going to do an ERCP. ERCP is a complex interventional procedure which combines science with art. The technique of ERCP actually requires a lot of cognitive skills which take time to develop. It's long practice which makes it possible. What we are going to do today is to show you basic ERCP techniques approaching the papilla, cannulation and removal of CBD stone. For this I am going to start the procedure with a side viewing scope. In general, the side viewing scope differs from the standard gastroscope in that all the instruments are to the side. And to show you this, let me show you the tip of the scope. The camera, as it zooms in, you can see the tip of the scope here. There is a working channel, there is an elevator here, and there is the light source. The light comes from the side. So, it is a side viewing scope. The difference between this scope and the standard gastroscope is that when you actually intubate with this scope into the esophagus, you do not see the esophageal lumen well, because you are very close to the wall of the esophagus. You see only the distal part of the esophagus. So, that is the difference. The initial intubation is different. Now, we are going to intubate this patient now. The patient is in a semi-prone position. We start first with a blind intubation, and because the tip is rounded, it is fairly easy to put it into the esophagus. Once in the esophagus, you can see that the scope is extremely close to the mucosa. So, you do not see the lumen actually. When I come to the distal part of the esophagus, what I do is to actually push the big knob down like this. When I push the big knob down, the scope turns, the knob turns towards the lumen, and you can see part of the lower end of the esophagus, and you can see this very nicely here. And as I enter into the stomach, I am now in the stomach, and the first thing I do when I enter into the stomach is to turn my scope to the left, extreme left, and suck out all the secretions here in the fundus, because these patients are sedated. She is on propofol anesthesia, so I do not want to take any risks of aspiration. So, we are sucking out all the secretions here, and once that is done, I straighten my scope and then I look for the lumen of the stomach. One of the things that you might have to do sometimes is to turn your knob a little right so that you can see the lumen better, and then the next step I would do is to turn the big knob down. When you turn the big knob down, the side viewing endoscope actually becomes a straight viewing endoscope, because the scope now faces up like this. And with this big knob down, I try to go down into the stomach, looking at the pylorus constantly. And you can see that I am going into the stomach. I am not distending the stomach too much, because we do not want too much air in the stomach. As I go down up to the pylorus, I will come to the area where I can see the pylorus well, and you can see that we are approaching this area now. At this point of time, I can actually look at the stomach, look at the incisura angularis, and look at the scope above. And as I go further down, I will come to the pylorus, and this is the area where the pylorus is. You can see it in the distance there. The technique of going through the pylorus is actually not to push your scope down like this, because then the scope will retrovert and go into the fundus, but to straighten the scope. And when you do this, what happens is the pylorus actually goes away from the side. So, it is called the sun setting sign. So, what I am doing is, as I am pushing, you can watch my thumb here, I am going to straighten the scope and push the scope. The pylorus disappears in the site as you simultaneously see it on endoscopy, and then it goes out of the view. You can see this now. So, I am now in the duodenal cap. Once in the duodenal cap, very close to the cap, you will see that the villi very nicely, because the scope is very close. And then what I do is turn the knob to the right, the small knob to the right, and fix it there. I then push the scope down a little so that I see into the second part of the duodenum. Once I do this, the most important steps come now, because if you actually look at the scope on fluoroscopy, you will see the scope is in long position. This long position is not ideal for cannulation. We will have to straighten the scope. So, what I would do is to turn my body to the right, to put the big knob up, and then pull the scope out. So, these three movements are very important. Turn the body to the right, put the big knob up, and then actually to pull the scope out. And as I do this, you can see on the fluoroscopy simultaneously that actually I am now going down into the second part of the duodenum and seeing the papilla there. and when I finish this procedure, you can see the papilla nicely in position there with a straight scope. So, this is how one should actually shorten the scope. So, it is very important that the scope is in this straight position rather than long position for all your procedures, and you can see very nicely here both on the fluoroscopy and on endoscopy that the papilla is facing us. Now, how do we identify the papilla? You will see that endoscopically there is a longitudinal fold which starts from the junction, the second and third part of the duodenum, and goes up to the papilla there. The papilla is a small mound, and on top of it you will see this very nice appearance of a villar type of appearance. This is typical of a frond like appearance, which is very typical of papillary opening which is there. You see also some bile coming out, which is a good sign for us. That means cannulation should be relatively easy in these cases. So, this is how a papilla is identified. Now, the next step is cannulating this papilla. For cannulation purposes, there are several options. There is standard cannulas that are available, there are sphincterotomes that are available, there are other special devices which are also available. My preference is to use a sphincterotome, because sphincterotome is nothing but actually a cannula with a wire attached to this. Now, the major advantage of the sphincterotome is you can actually flex the wire and move the sphincterotome up and down. As you can see, if the camera can zoom in here, you can see this coming and straightening, straighten. So, this advantage is there. So, you can actually lift up the papilla. What I am using for cannulation today is an Ultratome XL, which is a very short tip, a wire. There are several lengths that are available. Between 2 to 3 centimeters is the preferable length. Tip of the sphincterotome should be 0.5 mm or less, not too long, and you can see that this Ultratome XL has got a very smooth tip here, which is atraumatic, and this would be helpful not only in cannulation but preventing the problem of post ERCP pancreatitis. So, this is the sphincterotome that I would like to use generally, and we will cannulate now with the sphincterotome. Also, this sphincterotome has got a guide wire already in this. The guide wire that we are using is the Dream wire, and the Dream wire, the characteristics of the Dream wire, as you can see, the tip here is hydrophilic. There is a 10 centimeter hydrophilic wire. The other advantage of the Dream wire is that it is nitinol kink free. So, the rest of the guide wire is kink free, and therefore, it is much more easier for the assistant to use it. It is made of nitinol, and it has got a special coating on it called the Endoglide, which makes it much easier to move. So, this is a extremely good wire to use not only for primary cannulation, but because it is stiff and kink free, putting in accessories on this wire becomes also easy. So, now we are going to use this to try and cannulate. There are two techniques of cannulating the CBD. One is putting contrast and then looking at the anatomy and then cannulating. This is the contrast technique. The second technique is to use the guide wire directly to cannulate rather than the contrast. There is some evidence in the literature that if you do guide wire cannulation, then the chance of pancreatitis is decreased and success rates increase. Normally, a success rate should be more than 85% at the primary procedure to say that you are okay at ERCP. This is very important because a lower success rate would mean that you require more training. Now, the sphincterotome is out there now, and what I am doing is adjusting it in such a way that it faces the papilla, and then as I come to the papilla, I pull my scope a little into a comfortable position. The important thing is to cannulate towards the CBD. The direction of the CBD, as you can see here, in this would be from here going towards the 11 o'clock or 12 o'clock position. This is the direction of the CBD. So, if I have to cannulate the CBD, I must come from below and go up. For the pancreatic duct, however, the cannulation would be going from here towards the right at 2 o'clock position here, at 2 or 3 or 1 o'clock position. So, this is the pancreatic direction and this is the CBD direction. So, you can see the differences here. So, for the CBD, one has to tuck the scope down a little, go from a below up position, and then as I reach the lip of the papilla, I actually bend the sphincterotome a little. Sphincterotome is bent a little so that it takes an angle towards the CBD, and then I adjust the scope so that my position is in the central part. The papilla should generally be around 12 o'clock position. I get a small give to say that I am going deeper inside. At this step, I do not inject contrast, but we will use the guide wire to actually cannulate the CBD. The guide wire is pushed in now. We push the guide wire gently in the hydrophilic end, and you notice that the guide wire seems to be going into another duct, and this is the pancreatic duct. So, this is what happens sometimes initially when you are trying to cannulate, because now If you watch the fluoroscope carefully, you can see the direction of the wire in the pancreatic duct. So, this is the advantage of guide wire cannulation, that you do not actually put in contrast into the pancreatic duct at this stage. Now, we remove the guide wire back into the sphincterotome. I get my sphincterotome up to adjust it in the proper position to at 12 o'clock now, and then I am now going to put it up now. Can you flex? We are going to flex the sphincterotome completely so that it faces, see this, to pull the lip up towards the CBD and then pass the guide wire at this stage now. I pass the guide wire to see, and then you can see in this case the guide wire has now gone into the common bile duct. So, this is how the guide wire should be adjusted. If you are going into the bile duct, you come out a little and then you bend your sphincterotome, lift the lip of the papilla up and then go inside. Sometimes I found at this stage that if you are finding it difficult to get into the CBD very easily, to use an angled dream wire. The dream wire also has got an angled tip. If you use the angled dream wire and you can twist it a little, then it tends to go into the CBD very easily. So, now we are in the CBD, so I push the sphincterotome up, and one of the important thing is not to inject contrast at this stage, but to inject contrast when I go up right up to the intrahepatic duct. There are several reasons for this. One is at this point you get better filling of intrahepatic ducts. Small stones in the CBD will not be pushed into the intrahepatic duct, and you will not fill the gallbladder or cystic duct. So, for these reasons it is always better to start with contrast right up near the intrahepatic ducts. Now, the contrast up there, we inject usually for stone disease diluted contrast, 50% diluted contrast. We are going to inject the contrast now, and at fluoroscopy we are going to magnify the picture a little there and watch carefully. So, we inject small amount of contrast to see the intrahepatic ducts. You can see now very nicely the left hepatic duct. If the picture can be magnified in the top portion, you can see much better the left hepatic duct, the right anterior duct and the right posterior duct. So, these three ducts are made out very well. So, intrahepatic ducts seem to be okay now. What I am going to do is come slowly, and as I come slowly down, I am going to inject small amount of contrast, leaving the guide wire in place to delineate the bile duct. So, I am doing this now, and as I come down further, you can see the CBD is dilated. As we go down further down, you can see a small filling defect in the lower end of the CBD, indicating that there is a stone there. We are going to pull the sphincterotome further down as we inject contrast, and you can see the stone now very nicely in the lower end of the CBD. The stone is in place, as you can see from fluoroscopy, and we filled up the CBD. You can also notice that we have been carefully not filling the cystic duct or the gallbladder, because we do not want chemical cholecystitis that can sometimes occur with the contrast. The next step now is to do a sphincterotomy to remove the stone, and for the sphincterotomy, what I am going to do is to use, of course, the standard cautery attached to this Ultratome XL. There are very important steps in sphincterotomy, especially for the beginners to know, because these are crucial in not only a successful sphincterotomy but to avoid complications. I pull my sphincterotome out, flex it a little, not completely, flex it a little, keep only 1/3 of the sphincterotome inside, and then what I will do is that I will put the papilla somewhere in the middle of the field, so that I am very comfortable. I am away from the papilla, the scope is not too close up there, away from the papilla. I also use my elevator to pull the sphincterotome up towards the papilla, and then I am going to now use a endocut mode. There are several ways you can use this cautery. You can use pure cutting followed by coagulation, as some people do, or you can use a blended current, or the best now would be an endocut mode, which is available in most cautery machines. An endocut intermittently gives a cutting current with coagulation current. The chance of bleed are less with this, and there is evidence that probably the pancreatitis incidence does not increase when you use endocut. So, therefore, we use endocut. Now, what you will notice from my body movements here is that I have put my sphincterotome up against the papilla, only 1/3 of the sphincterotome is in. I am buzzing now for the endocut, and I am controlling the shaft of the scope to actually give me the actual cut. So, you can see I am pulling up like this. So, this gives a better control. There are various ways of controlling the sphincterotomy. You can control it with your up and down knob, you can control it with your elevator, also you can control it with your shaft movement. I like to use the shaft because it can be very precise here, and we will start using this technique now. I use a little body movements to get close to the papilla sometimes, but you can see that as we are cutting now, you can see it is important that you stop at the center, then evaluate how much you are cut, go in, come out, and then now I am going to bend the sphincterotome a little more to get better contact, and then now again I am using the shaft. I am pulling the shaft towards the papilla now, and then I am going to use the elevator to actually give the cut. And you can see now that we have opened up considerable part. Again, I am going in and out to be sure how much I have cut. And then the last part of the sphincterotomy is very crucial, because this is, you have to know when to stop. When should we stop this sphincterotomy? Now you can go right up to the edge of the duodenal fold as we are doing now, and as you do that you can see that two layers starting to appear. The top layer is the duodenal layer, and the layer you see below is actually the CBD. So when that starts appearing, that means you have completed your sphincterotome, and you can see this very nicely now, the two layers just below the sphincterotomy knife. So we have a few more millimeters to cut, and that would be the last part. You can see now I have cut, and this is a complete cut. Now how do you judge it's a complete cut? One of the ways is to go inside and then flex the sphincterotome completely, and the completely flexed sphincterotome is about 1 centimeter, should be easily coming out, and this is happening now. So we have cut this now completely. The next step is to remove the stones. The most frequently asked question is how much can we cut. In fact, in this case, for example, you can go a few millimeters more also up to the edge of the duodenum, but it all depends upon the stone size, the lower end of the CBD, how it is, and also it depends upon what you want to do subsequently, put in stents and so on. So if it's only a stenting case, then you don't require a big cut. If the stone is very large, and if it's going to be a square shaped stone, then you probably require a bigger cut. When in doubt, cut less, and you can use a balloon sphincteroplasty to open up the sphincter. That's another technique that's being used commonly now. We have now gone to the edge of the complete edge, and this is the end point of the cut, and you can see again nicely after remove the sphincterotome, you can see the layer, the CBD inside very nicely, the two layers, the duodenum and the CBD. I am going to leave the guide wire in place. There are two techniques of removing the stone here. We can use the technique, you can use a basket or you can use a balloon. This stone size, as we estimated on the fluoroscopy, is less than 1 centimeter. So my first attempt is to use a balloon. If the stones are larger than 1 centimeter, it is better to start with a basket, because then they don't slip out and they are easy to take it out. But if the stone size is smaller than 1 centimeter, the duct is not very dilated, the preference is to use a balloon. Now choices are sometimes made on other reasons too, that if you have large number of stones, then balloon may be easier because you don't have to go on using the basket repeatedly. So now we are going to leave the dream wire in place, and on this dream wire I am going to put a balloon to extract this stone. This is the standard balloon that I use. The balloon it can go up to different sizes, and you can, as the camera can zoom in, you can see that the balloon opens up. It's got an apple shaped appearance, and you can also, there are now balloons which are like CRE balloons which have different sizes. You can go from 8 millimeters to 1.5 millimeters depending upon the size of the duct. This duct is approximately 1.3 millimeters, so we might have to blow this balloon completely and drag it down. So what we are going to now do is to put the balloon on the guide wire. So whole thing is a guide wire technique now, and then there is a special technique of pulling out the balloon, which is very important, which I shall demonstrate to you subsequently. And you can see that as I am passing this balloon, the terminal part, the balloon is now going up, as you can see on fluoroscopy. I inflate the balloon right at the top there, so that I don't miss any stones on the top. Inflate the balloon, and then you can see on the fluoroscopy very nicely how the whole CBD is included with the balloon, which is distended. I am now going to drag this balloon down. I want you to watch both the fluoroscopy and the endoscopic picture as it is being done. You can see a lot of bile coming out there, frothy bile, and as we come to the terminal part, what I normally would do is not to pull the balloon directly down, but to use this technique where I hold the balloon. You can see the stone just below balloon on fluoroscopy. The technique of getting this out is to hold, I will hold the balloon with my left hand here near the scope, and then what I will do is I will push my scope down and turn my body to the right. As I push my scope down and turn my body to the right, the stone slips out and the balloon is in the longitudinal axis of the bile duct. So this is very important. The other way of doing this is to actually flip your big knob down, and when you do this also, the balloon tends to come down in the direction of the CBDs. After the end of the procedure, we must do an occlusion cholangiogram to be sure that you are not left anything behind. Now what you are seeing in fluoroscopy is actually small air bubble there. How to distinguish between stone and air bubble? One is the air bubble is perfectly round, And second, if you actually put your fluoroscopy table down, it tends to move up. We will do that now, head down. If it moves up, it's air bubble, it moves down, it is stone. So, it is static in position. Generally, if it is a stone, it tends to move up along with the table because gravity position. But if it is air bubble, usually does not do, stays in the same place or sometimes tends to come down. So, based on that, one can actually make a distinction. So, we will again do the balloon, inflate the balloon, check at that spot carefully, and you can see that we can compress this completely. So, it is probably an air bubble. So, now we do a final sweep here with the balloon. Again, this technique is very important, that we just put the scope, the big knob down, turn my scope to the right a little, and the balloon usually comes out. Deflate. So, that is the end of the procedure. ERCP is the most dangerous procedure that endoscopists will be doing. Today, diagnostic ERCP is no longer justified. Most often, to do an ERCP, there must be strong therapeutic reasons. Of course, many of these patients benefit from these ERCP procedures, but what is important is to justify these procedures in a proper way and avoid complications. Of course, training is very important for proper ERCPs, and if it is not properly done, a variety of complications should come. The most common being the post-ERCP pancreatitis, which can occasionally be very dangerous. To avoid these complications, it is very important that ERCP training is done a proper way, especially not only post-ERCP pancreatitis, but bleeding, cholangitis, a variety of other complications like again perforation can be avoided if ERCP is done in a proper way. The incidence of ERCP complications are approximately 9 to 10% depending upon the volumes in centers. In centers where the volumes are much larger, the incidences can come down to 2 to 3%. But it is very important that these complications are recognized adequately and treated so that potential benefits from the ERCP procedures are there for our patients.